Okay. So some of the conditions which require surgery, which you cannot refuse, like appendicitis and cholecystitis, trauma, which I also mentioned. So the main thing we have to take care of is maternal safety and fetal safety. So the physiological changes, you have to be very thorough with that. In all the answers, you can somehow squeeze it in and then introduce that as the first part of your answer. So you must be thorough with all the changes in pregnancy and which is their implications. That topic we discussed is very important. And these are all the drugs which you can use for safely, which also she mentioned, which they have that. So coming to the fetal concentration, first trimester within 1 to 12 weeks is a state of organogenesis. So prolonged maternal hyperthermia, hypoxemia, hypercarbia, hypotension should be avoided during this period. If you have to give anesthesia, that will safeguard the fetus. Coming to the second trimester, which is 13 to 26 weeks, which is the safest period for non-elective surgery. Even if it is elective or non-elective surgery, this is the safest period. And patients are considered to be at the lowest risk for preterm delivery. Surgical exposure is enhanced because the uterus is still in the lower abdomen and major embryonic development. Coming to the third trimester, 27 to 40 weeks, all concerns relevant to first and second trimester apply, but labor has not begun, so you can go ahead. Administering corticosteroids to facilitate fetal length maturity is very important if you are going to take up a patient for a surgery in the third trimester. And NSAID should be avoided after 32 weeks of gestation because of the premature closure of the patent ductus arterius. These two are the important considerations you have to remember during the third trimester. Elective surgeries in pregnant patients should be preferably done in the second trimester. Meticulous anesthetic techniques to maintain hemodynamic stability because uteroplacental perfusion has got no auto-regulation. So it is the maternal map which is going to determine what is going to be the blood flow into the uterus and placenta. So for sustaining the pregnancy, and so you should not allow the uterus to contract and expel the fetus. And regional anesthesia, as he said, is very safe because it does not cause any teratogenic activity and avoids the risk of intubation, aspiration, and all these things. And you can add additive for excellent postoperative analgesia. So this is the flow chart which you have to determine whether the surgery is elective, essential, or emergency. These are the three categories. If it is elective, you can delay until the baby is delivered, until the full pregnancy is over. Any elective surgery, for example, a rhinoplasty, you don't have to do it in a pregnant state. You can wait for that to happen after surgery. The pregnancy is over. Whereas if it is essential, sometimes you have to do it. So there's a mild difference between essential surgery and emergency surgery. Maybe a twisted ovarian cyst or an acute appendicitis or polycystitis, all these things. Whereas a gallbladder stone without any symptoms, it is not an emergency surgery, but it may turn out to be a emergency surgery, so it comes under the essential surgery category. So whichever trimester you want to do, you have to do, and this is another flow chart with which you can say when all of them will lead to the safest position or the safest time for surgery is second trimester. So whether it is essential or emergency, you can safely do, and any other elective surgery, you wait till the pregnancy gets over. The chief goals are to preserve maternal safety, maintain pregnant state, achieve the best possible fetal outcome. These are the three things. You have to save the mother, maintain her pregnancy, and achieve the best fetal outcome. Fetal monitoring all these times so that fetal heart rate variability you can monitor, and wherever possible you can apply the cardiotocograph to monitor the fetal well-being. And fetal resuscitation also, you must know how to do it with fluid therapy vasopressors and position adjustment, all these things. And monitoring the uterine contractions also is very important. Wherever it can be applied, it should be applied so that you can monitor and make sure that the uterus is not stimulated and contracted to expel the fetus. And postoperative analgesia, pain increases the risk of premature labor. So adequate analgesia is very, very important. And regional anesthesia or nerve plexus block epidural, all these things give very good postoperative pain relief compared to intravenous opioids, which can cause a fetal depression. Is the drug of choice for mild to moderate pain during any stage of pregnancy. NSAID should be avoided as said earlier. There are also associated oligoarrhythmias which can cause fetal renal function problems. And specific procedures, laparoscopy, you have to keep the inflation pressures to a minimum, bare minimum possible. Fetal and uterine status should be monitored. End-tidal CO2 and maternal arterial blood gases should be monitored. You can do cardiac surgery. Use of cardiopulmonary bypass increases perioperative risk. So factors related to cardiopulmonary bypass are fetal oxygenation should include non-pulsatile perfusion, inadequate perfusion pressures, inadequate pump flow, embolic phenomena to the uterine placental bed, and the release of renin and catecholamine. These are all the factors if you have got to go for CPB. And neurosurgery, of course, the various positions that you have to use, they can cause a risk. And of course, you do fetal surgeries like exit and all these things. So this is just an outline of what you have to remember for this particular question. But otherwise, what Dr. Nirmala has presented is really a very nicely structured answer for that. And I think she can share it with all of you for you to read and present it. Okay.